Hello, everyone. Thank you so much for joining. We are going to give folks just a couple of minutes to hop on before we get started.
Well, hello everyone, and thank you for joining us for today's webinar on using SDOH data to screen for social vulnerability. So a couple of things to keep in mind. All participants will be muted upon entry. Please make sure that you engage and submit your questions through the chat. Raise your hand if you would like to be unmuted. The meeting is also being recorded, and the slides and the recording link will be sent via email and posted to our website within a week after today's session. Okay.
Hi, everyone. Thank you so much for joining us today. My name is Saki Malik-Cho. I'm the Director of Research Policy and Health Promotion here at the National Center for Health and Public Housing. You just heard from Fide Pineda-Sandoval, my colleague at NCHPH. She is going to be helping manage this webinar and manage the chat and the polling questions. And we are also very lucky to be joined by a wonderful team at HITEQ, Molly Rafferty and Jillian Massini. Sorry, Jillian. HITEQ stands for Health Information Technology Evaluation and Quality Center, and they will be talking a little bit more about their organization in just a few minutes. Next slide, please. The National Center for Health and Public Housing's mission is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees. And we do that through training and technical assistance and research evaluation and outreach and collaboration. Just want to note that while we are funded by the Health Resources and Services Administration, our comments are our own and they don't necessarily represent the views of our funder. Next slide. So I just wanted to share a little bit of information about you, your registration data, just to get a sense of who is here on our call today. It looks like we have folks from all across the country, which is really great representation. We have a couple of folks from Maine, which is unusual. We normally don't get folks from Maine, so it's nice to see you guys here joining us. Puerto Rico, unfortunately, is not on this map, and that's my fault for not adding them there, but we do have a couple of folks from Puerto Rico. So welcome to all of you all, and thank you so much for making the time today. I also wanted to just quickly go over a couple of the questions that we asked you to provide. And it's just to help us kind of understand what the challenges and the strategies and the expectations are for you all so that we make sure we're addressing those things today. So one of the major challenges that you all mentioned is a lot of times about SDOH data is that a lot of times patients just won't tell you what's really going on in their life. And that makes it really challenging for us to help. And I certainly agree with that statement. I think a lot of health centers feel that same way. And it's a challenge because it's important to express the value of providing that information to patients and in the communities. And part of that is increasing the level of trust among patients in the population. And also, you know, if we're asking folks to provide data, provide information, having that follow-up, you know, what are we doing with that data to make their lives better? And I know that sometimes if a person expresses that they have challenges with housing, not having a place to live, and there are incredible wait times for getting into public housing, or if there's not a lot of affordable housing available, it can be a real detriment, like a factor that keeps them from expressing that need. So I think in our practice, health center practice of getting the data and having the follow-up and making a difference in patient quality care, you know, eventually we'll get to a place where that value will be seen very readily among patients in the community, and this challenge might start to fade a little bit, but that'll take some time. Some of the strategies that you all mentioned in getting SDOH data and using it appropriately is going to physician notes to get the information that you need, which is a good strategy. Using translators, certainly using the appropriate literacy levels when you're surveying your patients, which makes sense. Engaging patients at every encounter is a really great strategy, and it might address some of those challenges that we mentioned earlier in having patients feel comfortable in giving information at different times throughout their encounters at the health center. And then providing consistent surveys, and that can certainly help with getting the information that you need. A couple of the expectations that you all let us know: you're hoping to learn new strategies, understand where to send people for help, you know, what the most pressing SDOH needs are for patients, and some practical uses and procedures. So hopefully we'll provide that today. So thank you for giving us that information. Next slide, please. Here's our agenda. We are going to start with setting the stage and presenting just a case study that provides a patient perspective, and hopefully that will highlight you know, what the needs and challenges are from the patient. We're going to briefly talk about SDOH, what it is, and then I'm going to pass it on to our HITEQ colleagues to go through step number 3, which is gathering information about social factors, making sense of that information, and then using that information to support and improve care. Next slide, please. So this is our case study. This is Lucy. She's 20 years old. She grew up in a family of smokers where unhealthy food was the norm, and in an environment that was marked by domestic violence and substance use. After high school, Lucy got a minimum wage job in a neighborhood fast food restaurant. When she started working, she wasn't a smoker, but the pace of her job and the stress of living paycheck to paycheck really gave her a reason to start. Her employer was a small business owner. He didn't provide health insurance, but he did provide his employees with free meals on both ends of their shifts. When Lucy's over-the-counter pregnancy test was positive, she tried really hard to find a healthcare provider that would see her. And luckily, she found out that she was qualified for Medicaid. The health center that she went to for prenatal care was not in her immediate community, and she didn't have a car, so she had to use public transportation. She couldn't make it to all of her prenatal appointments because she had to work. And she also knew that she needed to eat more because of her pregnancy, so she began to eat larger amounts of the high saturated fat, high salty foods that were available at her job. She also knew that she needed to quit smoking, but she had tried before and really failed. And the stress of the unplanned pregnancy was really difficult to manage. Her neighborhood had no place where fresh fruits and vegetables were available. Her street had no sidewalks and it was unsafe. And without those nearby parks or recreational facilities, it was really difficult for her to exercise regularly. At 29 weeks of pregnancy, she develops a severe headache and visual problems, and she was rushed by taxi to the regional hospital where she was diagnosed with severe preeclampsia. When her blood pressure couldn't be adequately controlled, an emergency team delivered her premature son, and his lungs were supported for several weeks by a ventilator in the neonatal ICU, and eventually he was sent home. So this case example, unfortunately, is not uncommon. Luckily, it has a happy ending, but the struggles that Lucy faced and the environment in which she lived aren't unusual. And what I'm hoping over the course of this webinar is that you'll hear and see ways to document and track the concerns and the challenges that Lucy faced and identify ways to address them so that her story, that preeclampsia, could be avoided for future patients. Next slide, please. Social determinants of health are the conditions that impact our health and well-being, because where we live and work and play impact our health more than the medical care we receive. We understand that health starts in our homes and in our schools and in our workplaces and in our neighborhoods. And we know that taking care of ourselves by eating well and staying active, not smoking, getting all of the immunizations and screenings and seeing a doctor when we're sick, all of those things influence our health. But our health is also determined in part by access to social and economic opportunities and the resources and the supports that are available in our homes and in our neighborhoods and the nature of our social interactions and our relationships. And these conditions explain in part why some folks are healthier than others, and just in general, why people aren't as healthy as they could be. Next slide. Oh, sorry, I had added one slide and I see that it's not here, but the county health rankings and roadmaps developed a framework that illustrates this point very quickly, clearly, and it shows us that 40% of health outcomes are driven by social and economic factors and 10% by our physical environment, which means that at least half of our health outcomes are a result of what we call SDOH. So I would like for you guys to think about Lucy's example, and I just want to ask you, what social determinants of health do you think are impacting Lucy? And here are the choices that are available to you, and you can feel free to choose all that apply. I see someone put in other as an SDOH. If you wouldn't mind adding what you think is that other in the chat. Okay, Fide, do you mind ending the poll and sharing the results? Thank you.
Okay.
So okay, go ahead, Fide.
Okay, so I was just gonna read out the responses, and 88% said access to healthy foods, 88% said access to healthcare services, 75% said access to transportation, another 75% to safe environment, and 13% other.
Yes, and the other, it looks like, is finances, which is really important as well. So thank you for sharing that. I think those are all correct. And now we're going to pass it on to HITEQ to take it over from here. Next slide.
Give me just a moment and I will share our slides. Here we go. Oops. Everybody seeing them all right? Great. I am Jillian Mussini, and I'm joined by Molly Rafferty from the HITEQ Center here today. I realize that I do not have my notes up, so hopefully we're fine for this. We're joining you from the HITEQ Center. We are also a HRSA-funded national training and technical assistance partner. We work with fellow NTAPs, as with today, as well as with PCAs and HCCNs to reach health centers with the focus of optimizing the use of EHRs and health IT. And that can take a lot of forms. We have a little bit of a list on the right side of the screen. We do privacy and security, advancing interoperability, electronic patient engagement, readiness for value-based care, which we'll touch on a little bit today, and lots of other areas. We have a national website, which is hiteqcenter.org, which is full of health center focused resources, toolkits, trainings, etc. If you're looking for anything in our area of interest, you're welcome to just shoot us an email and we will do the searching for you and send along anything that we have. And then we also do learning collaboratives, remote trainings, on-demand technical assistance, things like that, which is what brings us here today. Our objectives after today's session are that you'll be able to describe how SDOH data, or what we'll call social needs data, that's the term that we've settled on, can be used to advance population health, particularly for vulnerable and special populations. Describe how to use social needs data to tailor services for more timely, patient-centered care, and describe the advantages and challenges of sharing social needs data with partner organizations in order to provide comprehensive and holistic care. We'll start by talking about gathering the information about social factors or social needs. Molly will walk us through that, sort of what the screening process looks like, what some of that information looks like, and some other relevant information that we can rely on sometimes. Then we'll talk about making sense of that information, sort of aligning it across purposes and requirements, and actually doing some risk stratification with it, and then using that to support and improve care for patients.
Okay, thanks, Jillian. So for the first section of HITEQ's presentation today, I'm going to talk about the importance of gathering information about social factors. This is often referred to as SDOH screening, and like Jillian said, we'll use social needs as our term of choice for today. Information about social factors can be gathered in a variety of ways. The information your health center gathers about patient demographics, such as zip code, age, race, and language, can be useful in identifying social needs. Social needs screening tools such as Prepare can also be used to gather social factors in a standardized way that assists with monitoring patients' needs, as well as monitoring needs across the patient population. These screeners or questionnaires tend to include demographics as well as questions about food security, housing security, financial security, access to transportation, social and emotional safety, employment, etc. Finally, health center staff should keep track of any social factors that patients voice outside of screening, such as requests for transport vouchers, disclosure of housing and security within the clinical encounter, or inability to access technology mentioned when recommending the portal or a remote patient monitoring device. I'm curious to hear from everyone where your health center is at in terms of collecting social needs information, and FIDE is going to go ahead and launch a poll to collect that information. Okay, we'll give it about 10 more seconds and then I think we can go ahead and close the poll. Awesome. So it looks like 56% of you said yes, that you're collecting all of the information mentioned and are actively using that information. 11% of you said yes, we're collecting the information mentioned. 33% said we collect demographics but are just getting a broader social needs screening approach in place. So all three of those answers mean that you're definitely in the right place today to learn more about this. Okay, next slide. So, as a reminder, each patient's social needs and related risks are likely to change over time. Patients' social need data should not be treated as static. What I mean by that is that someone may be experiencing food insecurity or housing instability, and when they are seen 6 months later, that may no longer be the case, or vice versa. Rescreening patients as frequently as possible to assess which of their needs are being met and how they shift over time can provide the most up-to-date information to work with. For those of you who are currently doing social needs screening, please share in the chat how often those social needs screenings are done. And as you all are chatting that in, I'm going to turn this over to Jillian.
Thanks so much, Molly. And we do want to hear from you all, especially those who say you are doing this screening and are actively using it. Would love to hear about how frequently you're doing so. One of the things that has come up a lot in the work we've done around this is sort of how to incorporate this information into the workflow without sort of doubling the length of every patient encounter and that type of thing. So we have a little infographic that we've made that I just dropped the link into the chat with some of the strategies that we've heard, because as Molly mentioned, one of the things that's maybe a little bit different when we think about these social needs as opposed to something like diabetes or hypertension or something like that is the sort of relative frequency with which they can change, right? So if we're thinking about something like housing instability or food insecurity, someone could be in a situation where they have unstable housing or don't have consistent access to food, as Saki mentioned in the case study earlier, but maybe their sister moves back to town and they're able to move in with their sister, share some resources in that way, increase their access to food in that. And so then sort of that one thing really shifts that patient's experience in terms of stability in their life. And we kind of want to capture that when that happens. And so thinking about how to include those things is important. So someone says we're using this primarily for specific populations, for example, the prenatal population, working on expanding more broadly. That's great. This is something that we've really heard in some of the work that we've been doing, is sort of going where the energy is, going where there's sort of agreement that this is needed. And I think, as the case example indicated, the prenatal population is obviously an area where this would be extremely important, especially if somebody needs, has transportation barriers and is not able to access those prenatal visits or something like that. Someone else says we conduct social screenings daily as part of the check-in process. We will determine if further evaluation is needed by the patient for further assistance by a community health worker. That's great. So let's jump in. And as I said, I just dropped a link in the chat with some examples of how we've seen this work out. Oh, see, I stopped sharing my screen so I could get my notes, and then I still didn't pull them up. Let's try it one more time. Hang on. There we go. Great. So one of the things, so Molly walked through some examples of screening for social needs, and several folks put examples in the chat. I'm also curious what you all are using for your social needs screening. I would love to hear that as well in the chat if you're comfortable sharing. Are you using the Prepare tool? Are you doing just single questions, maybe a food security question, or I know Medical Legal Partnership has some questions that they use. What are you using for your screeners? So one thing to think about in this sort of, when we think back to the content we said we were going to go through, social needs screening, or sort of identifying social needs in whatever way you do that, is used in many health center initiatives. So I think sometimes we experience these different initiatives as very standalone or siloed events or initiatives or anything like that. But one of the things to really consider is that social needs in particular, or social determinants of health in particular, are interwoven through many, many things in health centers. So PCMH, or patient-centered medical home care management, SDOH is a criteria through which patients can be identified for care management for the purposes of patient-centered medical home. And we heard, when we were doing interviews on this topic in the fall, we heard from many health centers that this was really the impetus for them really taking on SDOH screening or social needs screening in a more holistic and comprehensive way, was as a way to identify those patients for care management in a structured way. And we'll talk about that a little bit more, but it meets these PCMH criteria and also serves these other purposes. So the second potential reason, or the second initiative that also uses the same information, is UDS reporting. For those of you who are slightly familiar with UDS or not quite as familiar with UDS, UDS is the Uniform Data System reporting that health centers have to report on an annual basis. Sometimes it feels like this is a reporting requirement that's sort of like wholly separate from the work that you do on a daily basis, but there are 4 social needs that are reported on the UDS. It is housing stability, or housing security, I should say, financial security, access to transportation, and food security. And these are very much sort of some of the 4 key social needs that one might screen for as well. So one of the benefits of it being on the UDS is it can be sort of an impetus to collect this more regularly across a broader section of the health center patient population, in order to have those UDS numbers to report, but also, more importantly, to optimize care with that information. The third initiative that many health centers are engaged in, or at least have on their radar, that very much relies on or encourages social needs screening, is value-based payment. One of the key tenets of value-based payment and all payment reform really in healthcare is the need to identify rising risk, identify high utilization, identify high cost, things like that, and intervene and provide the care that folks need so as to get that condition under control, to improve their stability, that type of thing. So value-based payment really encourages both screening for social needs and doing something with that social need information, such as you doing risk stratification and sort of intervening. And as someone mentioned in the chat, often with community health workers, often with case management, these types of things. And we'll talk about some of what that looks like in a moment. And then lastly is community partnerships. One of the most revelatory things for many health centers as they begin to screen for social needs across their patient population is a real in-depth knowledge of what exactly their patients need. We have such a great example that we spoke to a health center about recently, where they had co-located their clinic with a set of community-based organization in their city. And so they were like, okay, so we're really going to be able to address our patients' needs because now we're in the same location as all these community-based organizations. And what they found as they increased their social needs screening is what their patients really needed was clothing. They did not have access to that, and that was not something that was in the space that they had moved into. So they moved these pop-up clothing drives. Clothing drives isn't the term they used. What was it, Molly? Clothing something.
Oh yeah, I can't remember.
Okay, I can't remember either. But and they were able to bring that right on site to the health center, and it was a real community partnership. There's an organization that they work with to do that. They do these pop-up clothing clinics on site, and it's a real opportunity for patients to have access to that while they're there. And so what I really want to demonstrate with this slide is the fact that these are not sort of separate initiatives, this single set of information, the single social needs screening, when implemented fairly consistently, which it sounds like many of you are doing, really furthers all of these things. And risk stratification is a way that can support all of these things too, and is part of most of these. And so we'll dig into that a little bit more. So I've used the term risk stratification a couple times without defining it. So what I'm really referring to there is the process of systemically using information about patients to assign a risk score or a risk status, not just for the sake of it, of course, but in order to optimize care across the patient population and ensure care plans and treatment address the patient's specific needs, right? And there are 4 basic steps to doing risk stratification. So the first one in the upper dark blue quadrant on the screen, if you can see that, otherwise you can just follow along with what I'm saying because I'm going to go through it. So that first one is determine what data you have and what patients the risk stratification may be used for. So some examples of categories of risk factors. And let me say, I really fully understand and appreciate that the terminology around this concept is not strengths-based terminology. And it's not my favorite, but I am going to use it because it is the common terminology used for these things. So just want to acknowledge that. So examples of categories of risk factors, meaning examples of data that might be used, are clinical diagnoses, and this includes, diagnoses of chronic conditions, things like that, behavioral health, special needs, chronic pain, substance use disorder, things like that. So that is your sort of set of clinical diagnoses that you might use for risk stratification or as risk factors that might be used for this purpose. A second category is potential physical limitations, non-ambulatory, declining eyesight, that type of thing. The third category is social needs, just as we've been talking about. Often the key social needs used for this might include experiencing homelessness, limited transportation, food insecurity, and limited English proficiency. Other examples that might be used that you might find appropriate for your patient population are safety, things like that. So social and emotional safety, for example, and those are included in many social needs screening tools and so can be embedded in this way. Next is utilization. The next category of potential risk factor data is utilization. So things like frequent hospitalizations, emergency department or urgent care visits, multiple specialists, or hospital readmissions. And then the last category that is commonly used and is not sort of a codified source of data, but is provider referral based on knowledge of the patient. And this is part of the PCMH example and some of the other ones as well. And so that could be confusion on medications, loss of the primary caregiver, things like that. That might be another reason that the provider would refer the patient for, which would increase the risk level for that patient. So the second step, the second quadrant of this plan is to establish an actual risk stratification plan. Molly chatted out a risk stratification action guide that NACHC has created. That is in the link, in the chat right now. But the basic plan is, what are the components that will be used to assess or assign risk? And so that is those data examples that we just talked about. So what data are we going to use? How will that be done? So the example that's shared in the chat right there is essentially, looks at number of conditions. And you can also use, if you're using something like the Prepare tool, there's a scoring algorithm that you can use there. So deciding how you're going to do that. And then perhaps even more importantly, why are we doing this? Why might we do risk stratification? So I pose that to you. What is the purpose of doing something like this. So we get all of this additional information, we screen our patients for social needs, we track some of this key information, and then what are we going to do with it? Why are we doing this? Why do you do it? For those of you who answered that you are currently doing it. And you can chat in or speak up, any of the above will be fine. Well, hopefully I'll give some ideas as to why to do it, but I would love to hear what sort of made you take this on for those of you who are doing this type of screening or who are implementing a risk stratification plan. So typically the reason one would undertake risk stratification to identify patients would be to identify patients most at risk of poor or worsening outcomes, of increased utilization and potentially of higher costs. Or as it says here on the slide, the purpose is really to optimize care. You know, we want to provide the right services and care to the right people at the right time. And in so doing, we're aligning our practice with value-based care approaches, right? With ways to provide high value care to our patients, which makes the best use of our resources, all of that. So that's sort of the theoretical why for this. The third step is you'll put the plan in motion. So you have decided sort of what are the components you're going to use to assess and assign risk. You've decided how you're going to do that. The next step is to actually apply that and assign your patients into risk groups. Now, as someone mentioned in the chat earlier, you could do this for a limited group of patients. Perhaps you're doing this for your patients with particular chronic conditions. Perhaps you're doing this for your patients who are assigned through a particular health plan. Perhaps you're doing this for your prenatal patients. Perhaps you're doing this for your patients with substance use disorder. Any of those is fine. You just want to look at that group, limit to that group, and then implement what you decided to be your risk stratification plan for that particular group. So you do not necessarily have to sort of figure this out for all 10,000 patients right now. You might start with a smaller group. And so during this phase, you'll sort of see how well the risk stratification plan you conceived in the second step is working. So for example, if you apply the components that you decided to use and how you were going to weight them, and you found that all your patients ended up in one risk status, right? Or you found that they were all high risk, then you'll need to modify your criteria to something that works better or gives you more manageable groups, right? So we always want to think about wanting sort of a normal distribution, right? Like if we think about a bell curve as what we mean when we say normal distribution, that's what we're aiming for here. We want, you know, let's say around 80% of the group we're looking at to fall in sort of the middle range, and that way give us sort of a small tail on both sides, which allows us to manage these patients successfully. So that's our goal. So if when you apply the plan, all your patients end up in one risk status, then you need to modify your criteria to something that works better and gives you more manageable groups. And then fourth, you want to create care pathways for each group. So again, if we're talking about 4 groups, we're talking about highest risk, you know, second highest risk, second lowest risk, and low risk, however you want to phrase those. We want to create care pathways for each of those groups if that's how we're breaking it up. In the NACHC example that Molly chatted out, I believe they break it down into 6 groups. So what that might look like, for example, is that those who are highest risk may have case management that specifically addresses their social needs and health needs in order to promote stability and keep them from experiencing worsening outcomes. And so if we think back to the case example earlier, it might be that Lucy gets case management that includes transportation to appointments, you know, a case manager who reaches out to ensure that Lucy is good to go to that appointment, that type of thing. So really the goal is that we're sort of directing our most intense resources towards those folks who are not stable or are at risk of becoming less stable or experiencing worsening outcomes. That can also be a great way to build a relationship to where patients feel more comfortable disclosing what they have going on. So we saw in one of the earlier slides that one of the challenges was getting patients to share their social needs, share what's going on. And that is absolutely a challenge. But through these relationships, through sort of meeting the patient where they are and providing that, right services, right care at the right time, that really does build that trust. Where patients can feel more comfortable disclosing what they have going on. So those patients who are in the next highest risk category or the rising risk might get some care coordination, such as referral to community organizations, slightly more hands-on follow-up, that type of thing. And you'll also want to check in with your care coordinators or your case managers, anybody like that, who can provide some feedback as to whether these care pathways are working as expected, right? And the other thing that I want to know is we also want to think about the low end of the risk spectrum, right? So again, if we think about it as a bell curve, you have a group that's on the lower end. And something to think about for those folks is that they might be best off with some more digital tools, things like that, things that free your personnel up from making phone calls, that type of thing. So your lower risk patients may be better suited to use the portal to get some of their results, or do some self-scheduling, things like that. And that can free up time and space for those other patients. So what does that look like to really operationalize that, or how can we think about that? And I mentioned a bell curve a number of times, but you'll see that the design that people really use to portray this is a pyramid, right? And so as I said before, risk stratification incorporates key information to identify groups. And we see here, hang on one second, that this includes clinical risk, as I said, social risk, and behavioral risk, right? So this is not any one of these, but it really is all three of these. And you see here, we've got the 4 categories. We have our highest risk patients, we have our rising risk patients, our at-risk patients, and our healthy patients. And these numbers on the side might not be what you experience in your health center. And again, this is really why I would encourage you to define your risk stratification plan, apply it, and then iterate on it until you get something that is manageable for your patients. And so you see here, the healthy patients are sort of identified as no ongoing physical health needs, might have fewer social needs, might have better access to technology, that type of thing. Your at-risk patients might be those at risk of developing a chronic condition or have one chronic condition, or are fairly healthy but have some social instability or some behavioral health, ongoing behavioral health things that create a little less stability. And then your rising risk patients, sometimes these are the real focus of this, because you want to keep them from becoming your high utilizers, or your high need patients or high risk patients. As I mentioned when walking through the risk stratification process in general, the point of creating these risk profiles or this risk stratification is to optimize care. Again, getting that right care and services to the right people at the right time to prevent that worsening or emergence of conditions. This pyramid shows the potential characteristics of each risk profile over here on this side. And then on the other side, it identifies some high impact care priorities. And so again, if we're thinking about our highest risk patients, these are the patients whose costs make up 45 to 50%, often experiencing social barriers, social needs, unmet social needs, often having frequent hospitalizations or emergency visits. these folks tend to have multiple chronic conditions and might be what would be called super utilizers. And on the right side of the screen really identifies what this might look like to have that intervention. Intensive transition planning, using, having access to the sort of admission, discharge, and transfer information for these patients makes a very big difference. So you can follow up when they get out of the hospital so they don't go back into the hospital, for example. You see in the medium risk, these are folks with limited but stable conditions. And the goal here is to typically provide team-based coordinated care, really allowing everybody to work at the top of their license, right? And then the lowest risk are those with minor health issues, really focused on coordination and prevention. And again, as I mentioned, sometimes this is the group that is best suited to virtual, mobile, anytime access, and can sometimes use those tools to free up time for the needs of other patients. And I hope this demonstrates well that your risk categories can be sort of any number. It can be 3, 4, 6, whatever works for you. And risk stratification really drives these insights. And again, what is on your sort of high impact care priorities? This graphic here can help illustrate that, but it will depend on what your structure of your health center is, right? And so the key thing to think about here is that each health center can only respond, or each provider or anybody doing this work can only respond to identified risk. So good information and access to that information really is key. Sort of having that structured, standardized approach that you're able to follow over time is really critical to being able to make use of this. And so there's a couple key components to think about when we're thinking about this. One is that there may be an algorithm built into your EHR or health IT system. If that's the case and you want to use it, that's great. That's a really good place to start. It is very important to ensure that it's mapped and pulling correctly the relevant information, the information that you've identified, so that it's accurately representing patients. One of the things we always want to stress when we think about using tools like an algorithm of this sort is that rarely are these things just plug and play. You just start using it and it's good to go. And we don't need to validate that for our patients. It's very important to understand what's going into that algorithm so that you really understand what you're making decisions based on and what your patient's real needs are. So very important to ensure that that is mapped correctly, is pulling that relevant information in, and is sort of pertinent to your health center's patients. The second thing is care design across. You really want to have your care designed across the clinic with these risk groups in mind. And what I mean by that is the timing of follow-up, timing of referrals, checking in on referrals, that type of thing is going to differ by these different groups, by the relative stability of any of these groups. And that is really important to consider when you are sort of making your care plans and your treatment plans. Also very important to have actionable policies on how to use the risk score at the point of care. So if we go back to where I was walking through those sort of 4 steps as to what risk stratification is and how it might be implemented in your health center, creating those care pathways, like really ensuring that everybody in the clinic understands that we're using this risk stratification in order to support that decision making at the point of care about what this patient probably needs to be successful. Ensuring that they get whatever that is. And then lastly, thinking about multidisciplinary care teams, including patient engagement and outreach beyond the walls of the clinic. And by this, we really mean digital tools. So I've mentioned the portal a couple times. Some people hate their portals. I totally get that. So it could be some other tool. A number of health centers are using things like Care Message or Luma Health to do sort of SMS outreach to patients, make sure that patients get those reminders about their visits, get their reminders about their medications, those types of things. And so it might be that, plus some CHWs doing some outreach as well, really thinking about how that care should be that patient engagement should be allocated across those risk profiles in order to ensure better outcomes for those patients. So these are sort of the four key things to do with this information in order to make sure that we're making best use of it and improving care. So I will stop there. What questions, comments, thoughts do you all have, or what have we not addressed that you would like to talk further about? Or what does it make you think of as it relates to the case study earlier? I believe the presentation will be archived. Perhaps Fide can tell me.
Yes, that is correct. And we will be sharing the slides and the recording with everybody.
Great. So yes, Tom, you will have access to this. Sure thing. Any other questions or thoughts anybody has?
Jillian, thank you so much, and Molly, for that excellent presentation. You covered so much ground in the presentation. So it sounds like people are just kind of thinking through maybe all of the information that you provided. I was wondering, because you talked about it being kind of a process, right? You create this plan, this risk stratification plan, and how it sometimes needs to get modified.
Yeah.
Can you talk a little bit about, how, like, who on the team, like what staff is responsible for kind of looking through that data, and how does that fit into the overall workflow?
Yeah, that's a great question. So, like all things, it depends, but mostly what we would be talking about in that scenario is your whoever is looking across your patient population. So that might be a population health coordinator, it might be a data analyst, it might be a quality improvement person, but whoever is sort of doing that, like look across the patient population to see what we have going on. Could be a business intelligence analyst. We've seen it be sort of all of those people. So it's usually that person who says like, hey, when I run, when I write a query that pulls these things in, or when I write a query that like gives these scores, or when I apply the algorithm that our EHR has available, I'm seeing that like most folks are falling into, maybe our level 4 or whatever. That's oftentimes that person, your population health person, your data analyst, your business intelligence analyst, whatever that role is. But the other place that the really key insight comes from is the provider who says like, hey, I want to use this information, but every patient I'm seeing is red. And so I don't really know what I'm supposed to do with that. So it's really those two folks getting together that really kind of makes the magic there. And really whoever is doing the implementing, the applying of whatever your risk scoring is, hearing from providers as to whether this is actually providing actionable information is really critical. And then vice versa, right? The providers have to say like, okay, yeah, I know how we can use this. We can plan to do this. And, and then you get, and sort of as it rolls forward, your clinic managers or your CHWs, your MAs, your nurses, all of those folks say, hey, here's what we have found works for patients. And so we can make that part of that care pathway. And we're going to save this for this care pathway because these folks really benefit from this. And so it really, as with all things, is totally a multidisciplinary approach. But in terms of really iterating on it and coming up with something that works for your team. It's very often like your population health or quality improvement person and your providers who are sort of bouncing back and forth a little bit initially, just figuring out what's going to work for you all.
That's really helpful. I know we have a whole swath of staff on this call. So we have, C-suite, but we also have care coordinators and managers on this call. So I hope that explanation that Jillian provided really shows you all how you might fit into this model and into this process.
And, you mentioning care coordinators really makes me think of something else. Is care coordinators have such an important role. And it's like, how do you make best use of the care coordinator available time, because so many people could benefit from it, right? And so one of the things to think about is okay, where do our care coordinators find that they're really able to make a difference versus who do we need to come in for, clinic visits more regular, and thinking about those types of differences. And everybody has such knowledge of the patient. As we said, that's one of the data criteria is the knowledge you have of your patients. That's a really important part of this as well.
Yeah, I agree. I mean, I think the CHWs, the care coordinators, are really critical to providing that information to
and such a source of trust.
Yeah,
mm-hmm.
Yeah, for sure. Well, I want to thank you guys again. I don't know if there's any more questions in the chat. Thank you so much, Jillian and Molly and FIDE, for managing this webinar. Yes, a reminder to please fill out the evaluation poll. And if you have any other questions, you can contact us and we will follow up with you. The slides, the recordings, all of that stuff will be emailed to you. It'll be available on our website. We'll also include those links that Molly and Jillian put in the chat for those resources that are relevant to this webinar. Thank you again and enjoy the rest of your afternoon. And there's our contact information. Thank you so much.
Bye everyone.